Hello, everyone. Welcome to the Global Ultrasound Institute's webinar on POCUS and infectious diseases from fast to FASH and beyond. I am beyond excited. My name is Mena Ramos. I'm a family physician and the co-founder of Global Ultrasound Institute. And we are just beyond excited and to share this platform, this webinar platform, with an incredible POCUS expert researcher and a real innovator in the field of point-of-care ultrasound in infectious diseases in resource-limited settings. If this is your first webinar with Global Ultrasound Institute, welcome. We are a community of POCUS passionate clinicians dedicated to uplifting the practice of medicine through education and training of point-of-care ultrasound, and really partnering to develop and implement scalable solutions to get POCUS as available as possible. And if everyone could please mute yourselves, that would be great. We are just about to get started here, and we are excited to be hosting Dr. Tom Heller, who is a leading world expert in POCUS and infectious disease. I've been a huge fan of his work for over a decade. And Dr. Heller, if you could please introduce yourself as we get started.
Yeah, thank you. Well, let me see. I need to quickly see my list. No, thank you, Mena. It's a great pleasure to be with you, and you make me sound bigger than I am. So I'm not a big researcher and not a big innovator. It's just that I'm a clinician working in a setting where in these point of care ultrasound is often the only imaging you have, and of course if you make diagnosis then by imaging, then it leads to the fact that you use a lot of POCUS, and then if you report on it, you get known, because not so many people did it 10 years ago or I don't know, 15 years ago when we started. So yeah, it's a pleasure for me. I'm an infectious disease and internal medicine physician, originally from Germany, so excuse the accent. But I'm working for many years in Saudi Arabia, in South Africa, and then in Malawi for the last 7-8 years. And my main point of interest is tuberculosis, HIV, and hepatitis, but also, of course, other infectious diseases if they come along. So and ultrasound is for me I don't want to say it replaced my physical examination, but it definitely boosted and adds to my physical examination. And I say now I can't think without an ultrasound machine. So it seems my brain is down on that.
I think many of us on this webinar who use POCUS in daily practice would absolutely agree with that. I also wanted to introduce Dr. Kevin Bergman, who is a co-founder of Global Ultrasound Institute and will help us with the conversation as we go through some cases and updates. And if you have any questions, please feel free to drop them in the chat over the course of the next hour. We will field some of these questions throughout. So without further ado, I just wanted to start by framing our conversation today about POCUS and infectious diseases in resource-limited settings by understanding the kind of global landscape that we find ourselves in. And still, despite advances in technology, portability, accessibility, telemedicine, et cetera, we still find ourselves in a world where half of the world approximately has little to no access to diagnostic imaging. And so enter point of care ultrasound. And we use this word POCUS, point of care ultrasound. There's lots of different kind of bedside ultrasound, a focus exam, et cetera. But what are we really talking about when we use that word POCUS? And why is this such a kind of transformation beyond just an expansion in terms of the kinds of equipment that we're using, but it's when we think about the workflow or traditional practice, where a patient sees their medical provider, and that person orders an ultrasound. It's traditionally a circuitous route where that ultrasound may be scheduled, or that person has to go somewhere else, to a radiographer, a sonographer. And so this circuitous route, while certainly necessary in many clinical contexts, does pose many barriers, even when it is available. There are many barriers to all of these steps. And so what we found is that many patients get lost to follow-up, or these options, this road is not even available. And so enter point-of-care ultrasound as a bedside tool that really can streamline diagnosis in an immediate way and really bridges that the patient and their clinician. And so there are definitely some key differences with POCUS and a traditional route. And when we think about, resource-constrained settings, I think over the next hour, we'll talk about different cases. So the clinical context and a patient-centered approach is a theme that we're going to repeat over and over and over again, that we're going to consider both epidemiology, and also other resources that are available. Because at the end of the day, this is not POCUS is not something that's isolated to a tool or an image or an interpretation of an image, but rather a reimagining, a re-engineering, a restructuring of our clinical workflow so that patients can get better care with fewer barriers. So how can we decrease those barriers while centering patients and always considering the clinical context? So with that, just taking a step back, looking at POCUS from a global policy lens and the Sustainable Development Goals, POCUS can address multiple Sustainable Development Goals. And thinking about just one in particular, good health and well-being, the role of POCUS is expansive, is cross-cutting and expansive, and looking at kind of the top 10 leading causes of death in according to the World Health Organization, specifically in lower income countries. We can find examples of where POCUS can address multiple of these issues from a both earlier diagnosis standpoint or a recognition of complications standpoint. So without further ado, I'm going to pass the baton to Tom. We'll go through a few cases that really illustrate some of the research that he has been involved in, and I think may be very interesting to everyone on this call. Tom.
Yeah, thank you, Mena, for that. I want to start with a case. So I think we have three or four cases. I want to start with the case that a lady who I saw quite a while ago in South Africa, and that was in KwaZulu-Natal. And KwaZulu-Natal in 2007, probably like today, was the epicenter of HIV epidemic and of TB epidemic. So that's the context, maybe. And I was working in a small district hospital, and there we saw this 22-year-old female patient. She reported weakness, intermittent diarrhea, and that she had lost lots of weight. And additionally, she complained about hiccups and mild abdominal discomfort. So on examination, her abdomen was mildly tender, but no peritonitis or anything. We did some blood investigation, which was basically an FBC, and that showed a normocytic anemia of 7.1. She tested positive for HIV, not a surprise in the setting, and her CD4 count, which we were able to get, was 23 cells. So what would be today defined as advanced HIV disease, quite obviously. So, and looking at this patient, you will see a lot of people who treat patients in this setting will already smell that this is TB. And what we did next is that we did a chest X-ray, but the chest X-ray did not show us any sign of TB. And sorry, Mena, that was to and fro, but you can go ahead. The next thing we did was to do an ultrasound. And the ultrasound, this is an ultrasound scan of the upper abdomen, a transverse scan. So basically what you see is the liver in close to the transducer, which gives us an acoustic window to the area behind the liver. And in that area behind the liver, we see a lot of nodular structures. I mean, there are some, they are more hypoechoic, they are darker than the liver tissue. But we can see that as the transducer moves up and down, you see them blinking. They get bigger and smaller, bigger and smaller. And that is a typical behavior of a round globular object, yeah, on ultrasound, that when you pass with a transducer of it, you get this nodularity, this roundness. And of course, behind the liver, in the area of the pancreas, periportal, periaortic, there are no other round organs than lymph nodes. So this is actually a very typical clip of a patient with enlarged, massive, well, not massive, but many enlarged abdominal lymph nodes in the upper abdomen. And that, of course, is very suggestive in a setting like KwaZulu-Natal, but the same is true for Malawi. That is very suggestive of TB, because TB causes enlarged lymph nodes. Of course, there are other reasons that cause enlarged lymph nodes, but this is definitely one of the frequent ones. What we also scanned quite then is on the next, I guess, the next slide. Yes, the next slide shows you the spleen, and you can see that what in the spleen tissue. And first of all, you can see maybe something that might surprise you, because few people use a linear probe to scan the spleen because it's intra-abdominal. So you would normally use a convex probe. But what we found over the years, and well, you find it in 5 minutes if you try, that the linear probe is much more sensitive to detect these lesions in the spleen. And so let's look at the spleen tissue. Again, it is a grayish tissue. And inside you see, again, this darker hypoechoic, well, maybe 0.5 centimeters on average, I would say, dark lesions in the spleen tissue. And that is, again, a very typical picture of microabscesses. So microabscesses in the spleen. Is TB the only thing that can cause microabscesses in the spleen? No, but TB is something that causes it very frequently. So, or it is a very frequent cause of microabscesses. Maybe we have to say it that way around. So again, we have a patient who is clinically, epidemiologically in the right setting, where we expect HIV-associated disseminated TB. We don't find anything in the chest X-ray, but we find the abdominal lymph nodes, and we find the microabscesses. So that is, in our setting, usually enough to say, well, let me better start TB treatment. Next slide. Well, we found that, and of course, it doesn't make much. It doesn't help much if there is one or two German doctors in the middle of nowhere who do this. So what we developed a protocol, which we, of course, you guessed it, we modeled it on the FAST protocol. It's called focused assessment with sonography for tuberculosis. Would have been FAST, was taken, so we called it HIV-associated tuberculosis. And then it's fashion. That sounds good, sounds fashionable, sounds fashy. And what is it? It's basically a protocol designed to detect signs of disseminated TB, particularly in HIV-positive patients living in high prevalence settings. So why do we need that? Simply because we know that patients with advanced HIV disease, especially when sick and hospitalized, they often suffer and die from disseminated TB without being diagnosed, because there is no single simple TB screening test available. And we knew, and we know today even better, that pericardial effusion, unilateral pleural effusions, enlarged abdominal lymph node, and spleen lesions are relatively specific. And TB treatment in general is likely available. How do we scan for that? Next slide. We basically use the same 6 windows that the FAST scan uses. We use the window 1 to detect pericardial fluid and add on the upper abdominal lymph nodes, which I showed you in the clip. Number 2 is for pleural effusion. Number 3 is for ascites in the Morrison pouch. Number 4 is for pleural effusion on the left side. Number 5 is for the fluid in the splenorenal recess. And number 6 is for ascites in the Douglas. And then we use again, as I said, the linear probe in position, well, whatever, 4 or 5, and that looks for spleen microabscesses. Next. How good is that? And I think that's that one we know relatively well today, because not because that I had contributed to these studies, but a lot of people looked at it. And basically, I want to look particularly at the lymph nodes and the spleen lesions, because these are not necessarily pleural effusion and pericardial effusion were well known and but already in WHO guidelines as typical signs. But what you can see here, that the lymph nodes, we have by now 10 studies in including more than 1,500 HIV positive patients, most of them in sub-Saharan Africa. And you can see that the sensitivity of these signs is really not good. 39%, that's nothing to shout about. And that is in a way logic. The specificity, on the other hand, is 89%. Yeah, and it's also much more homogeneous. You see that the sensitivity is spreading from left to right. The same is for the spleen lesions. Again, we have 8 studies with over 1,500 patients. Sensitivity is 30%, specificity 93%, which is better. And yeah, why is that? Why is the sensitivity so not so good? Well, if you treat TB, or if you diagnose TB, you will know that. I mean, obviously, TB, what we are looking for is signs in the spleen and in the abdomen. So, but a lot of cases are pulmonary TB. There is other TB. There is spine TB. There is, and there are often cases of TB which show no abnormality at all, and still they are TB. So the sensitivity cannot be expected to be perfect or even very good. But the specificity, if you see the signs, then it is indeed quite good indication that you are really looking at tuberculosis and not at, well, possibly at something else, but not likely on something else. Next one. What we ask ourselves then is this teachable? I mean, because again, as I said, if it's not teachable, then it cannot really be rolled out. If it cannot be taught easy. So we developed a short training course, which was basically 2 days, where we trained the residents or the interns, more that you would probably say more interns at our district hospital. We trained them in the method. And after the weekend, we said, well, you just scan. And if you find something, then you call us, and then we scan against that as the gold standard. And it was a very small study. And I think that the American Journal of Tropical Medicine more published it because they liked the underlying idea than the scientific rigor. But definitely it is teachable. That one we can say by now. And I think maybe at this point, I would pause briefly, and because that is maybe my introduction to FASH. I don't know if there are any direct questions to this one. Mena, back to you.
Yeah, thank you. Thanks, Tom. When I think about POCUS and infectious disease, like the first protocol that I think of is the FASH exam. I'm just to kind of center the conversation around the clinical context and how this is really useful. How can this be useful? You mentioned these numbers, the sensitivity and specificity numbers, and the sensitivity being really low. Would it be fair to say that as an exam, this could, as opposed to a rule out exam, this would be more of a rule in for extrapulmonary TB in a setting where you have a patient in a high prevalence setting with that as clinical symptoms suggestive of TB, but no confirmed evidence on imaging or labs, and so you're looking for other forms of evidence with POCUS to be able to start treating this person for TB. As a rule-in test, but if it's negative, I guess I just want to kind of hear, like, from a clinical perspective, like, how does this change your practice as kind of rule in, rule out, and
absolutely what you say, it's correct. I mean, what for example, what we use FASH for all our patients, for example, for inpatients. So it's more likely to be positive the sicker the patient, right? So in inpatients, it works. It is more often positive, but it works also, of course, in outpatients if they are sick. So, and then it is indeed, like you say, it's a rule-in test. Once our clinicians find it, they will say, oh, let me start TB treatment. If they don't find it, they do not say, okay, this patient does not have TB. That's not that you have to search other, you have to try other things. We have urine alarm, we have gene expert of the sputum, we have so many tests, and even, like I said, often we even have clinical empirical treatment with checking after 4 weeks if the patient gets better, and that can also be making the diagnosis. So it is absolutely, like you say, it's a rule-in test, and it is by no means a rule-out test.
Great. And as far as the protocol, you also mentioned pericardial and pleural effusion, but didn't mention like kind of accuracy numbers, sensitivity, or specificity. Any comments on kind of the pericardial and pleural effusions and what you kind of would anticipate, or clinically what we know and also what we don't know?
Yeah, thank you. I mean, that's funny, because initially we thought with the as I said, with the pleural effusion and with the pericardial effusion, we felt we are on safe grounds, because it was, if you look at the WHO guidelines on diagnosing extrapulmonary TB, you will find these two mentioned. But frankly speaking, today I'm much more certain on what we have on lymph nodes and spleen abscesses, because that is, I think, much more closely looked at. I think pericardial effusion in an African setting, or in the right HIV/TB setting, it can be in Asia or in any setting where you have the right South America, any setting where you have a high prevalence. Pericardial effusion is quite highly connected to, especially if you only have pericardial effusion. If you have multiple, let's say if I find in my exam, I find pericardial effusion and pleural effusion on both sides and a little bit of ascites, then I would not think that this is TB. Then I would think this is maybe just fluid overload and the water is going everywhere. So I think there is much more, in a way, with the effusions today, I feel there is much more clinical thinking required than with the lymph nodes and the spleen abscesses. So I think that's maybe, and it also depends on the setting. If you do this let's say, for example, in our clinic here at Lighthouse in Malawi, we're treating a lot of Kaposi sarcoma patients, and you will find that they have a lot of effusions. So it's not really, if we checked here, we would probably see that a lot of our effusions are due to KS, but that's simply because a lot of KS patients are referred to us. So but it's still, you need clinical thinking. That's what I might say.
Yeah, thank you for that. And as clinicians, centering the clinical context, like as I mentioned from the beginning, that this theme will constantly come up. But I do think it's important to note that these are very teachable and learnable exams, and that has been documented throughout the literature, including for this, I would say, arguably even more complex exam, because it's multi-part, involves the abdomen and the chest. And before we move on to the next case, I just wanted to share a comment from Dr. Bruno Vargas, who works in Mexico with Partners in Health, that this can be not only a diagnostic tool, but also a way to be able to advocate for treatment, access to treatment for patients. With that comment, thank you, Dr. Bruno. Let's move on to another case and exam.
Yeah, this is a case now from Malawi. This is a boy who came, I remember he came with his grandmother, and a 15-year-old, and he was referred because he was increasingly, he was for a long time short of breath and had ascites and particularly lower lymphedema. Here you see his vitals, so more or less normal, but there was a murmur which the clinician cannot understand, and I didn't understand it neither, because I'm not very good anymore with listening to the heart. But this is his chest X-ray, and we obviously see that there is a very large heart, and this cardiomegaly is the topic of the next case in a way, because what we see a lot is that this is maybe our second commonest question here. We have a big heart. What's the underlying cause? So what do we do? Well, obviously we do an ultrasound. That's why we're doing this webinar. That maybe we can see on the next one. This is his ultrasound, and what you see on this ultrasound, and maybe I orient you again, we're using the same view that from the other protocol, the epigastric view, and we angle it upwards. We only use this, we mainly use this view. So we again have the liver in front, which is basically the acoustic window. And then as we go back, we see the right ventricle and the right atrium. There's the right ventricle and there's the right atrium. And then we see the left ventricle, which is comparatively small in a way. And then we have the left atrium, which is the big circle there. So that is the biggest increase in size in this heart is somehow in the left atrium, and that of course suggests that there is a problem in the mitral valve, because there's a blockage, there's a traffic jam in the mitral valve, I would say. So that is suggestive of a mitral stenosis. And in our setting, mitral stenosis is not that rare. It is much more common because we have still quite a number of cases of rheumatic heart disease. And this case illustrates maybe what led us in the next slide. Led us to think about what can we do with the ultrasound for cardiac diseases. And what we did is we did a bit of a ranking, and basically we, together with others, we looked at what are the most common findings that affect our patients in the sub-Saharan African region. And we ranked them and gave them, for very frequent ones, we gave them 3 points, for medium 2, and for rare 1. So it's basically a very, it's more of a go by the thumb rate ranking. Yeah? We looked at the prevalence, we looked at the impact. So what if I can diagnose it? How much can I change my treatment? Do I have something to offer to the patient, or is it life-saving? I give it a 3. Is it, well, I can change something? Is it 2? And if I just say, well, it doesn't change much, then I give it a 1. And then the final criteria is the difficulty. And again, if it is very difficult, then I will think twice. So I give it only a 1. If it is easy, I give it a 3. And with these points, we basically rank them. And you can see here, there are the top 5 that is that we included into our protocol. And I think the next slide should show you the protocol, which we called cardiac ultrasound for resource limited setting, or CURLS protocol. We were already in the fashion world going. So this is a protocol for patients with shortness of breath, cough, edema, and radiologically enlarged heart, if you know it already. But of course, if you don't have an X-ray. Why do we need it? We need it because pericardial effusion is frequent, often due to TB, as I said before. Left ventricular failure is often very advanced. So it's not really that we are dealing with ejection fraction. Is it 50 or 40? No, we are really, very often our patients come with an ejection fraction, which is terrible, down at 10%. It's hardly pumping at all. It's basically just vibrating. We see cor pulmonale far more frequently, and finally, because post-traumatic mitral valve disease is also far more prevalent in our setting than in the European American setting. So what we do, we also found that 4 windows are slightly too complicated. This parasternal long and parasternal short, they are not really intuitive. I think we think the epigastric is much. We think that the epigastric window gives you much more of an anatomical thing that you can easily understand. So it asks 5 questions. Is there a pericardial effusion? Then we would think about TB. Is the left ventricular function massively reduced? Then we think about cardiomyopathy. Is the right ventricle bigger than the left ventricle? We think of cor pulmonale. And I think up to here, probably this is still quite a normal protocol, like many other protocols that are there. Is the left atrium bigger than the left ventricle? We think about rheumatic mitral problems. And is the septum thicker than 12 millimeter? That's the only measurement that will give you an idea on the left ventricular hypertrophy and on that. Next one. I want to share just some clips for you. So this is of course a case of pericardial effusion, and you can see that there is the heart pumping, and you see this black You see this black rim around it. Inside the black rim, you can see that there are fibrin fibers floating and moving. So you don't need to prick a needle in to see that this is an exudate, not a transudate. And this is a typical for TB, but of course also for other things. Next slide. So here we see the problem of the left ventricle, which you have the arrow now. There's the right ventricle, here's the left ventricle, and you see that the left ventricle wall, it's basically not pumping. It is really just it's an ejection fraction from, I don't know, 3%, or I have no idea. So very, very low. Yeah. So this is then due to cardiomyopathy, and well, and of course it has a different treatment than the pericardial effusion, because this one would need anti-failure treatment, and we have ACE inhibitors, we have diuretics, and we even have spironolactone very often. Next one. And I think that's the last one that I want to show again. You see, if I think of the 5 questions we ask, is there a pericardial effusion? Yes, there is a tiny pericardial effusion, but that is indeed not the problem here. And the next question, is the left ventricle in the distance pumping? It is pumping quite well. If you see that, it's moving. But then, is the right ventricle bigger than the left ventricle? And I think that's a clear yes. The right ventricle is humongous. This is more than almost double the size than the left ventricle. And you see these muscular trabecular structures. So this is a chronic cor pulmonale, and that is quite frequent finding in our setting. And well, then so this is just to give you some examples of the cardiac ultrasound curls protocol. And down here you have the citation if you want to read up on it. Yeah, it's an open access in the ultrasound journal.
Well, thank you so much, Tom, for taking us through the curls protocol. And please feel free to drop any questions in the chat. You didn't specifically mention trainability for the curls protocol, unlike the FASH protocol, but just as a comment, and we've seen, at least from the ER literature, a focused cardiac protocol is in fact trainable and learnable by non-cardiologists. So as a product, like as curls, as an even more, in a way, simplified focused cardiac protocol, and that you're really looking at one subcostal view, I think it'd be safe to say that this is indeed a trainable exam. The slide that you showed on these kind of 3 different indices, the prevalence and does this change clinical management and treatment is extremely interesting, because I think it recenters the clinical context once again. And we're just getting a lot of comments in the chat of how these protocols have been useful for clinicians really all over the world. So Tom, I'm not sure if you're seeing this. But I did have a kind of a question around kind of developing another cardiac protocol. For those of us in POCUS and POCUS education, there are many protocols and lots of acronyms. And around cardiac ultrasound, having existing protocols, I'm curious to hear from you and your group, kind of as you were developing curls, what was kind of the leading impetus behind developing another cardiac protocol?
Yeah, it was indeed. I started mentioning it. I think it was I mean, it was simply that's the 2 things. Number one is we found that most of that we can diagnose in a single view. So we wanted it simpler. That's one thing. And the other thing is that indeed, again, like I said, the rheumatic heart disease is well, it's not in general protocols because it's not relevant. I mean, it's something that probably few cardiologists today diagnose, and definitely not on a daily basis. So it would not be very useful to put it in protocols, because you teach something that you then don't find. So and that and additionally also the cor pulmonale. I mean, we see it really, really frequently. I mean, we see particularly, I mean, maybe to mention it's also in the beginning, and maybe also the consequence, because I mean, obviously, if you think if you in your setting, if you see corpulmonale, then probably your next thing will be to say we should look at DVT, right? Because that's there might be pulmonary embolism, because that's the most common reason of an enlarged right ventricle in your setting or in the American setting. For us, it's different because we have, I mean, we still, we would do it, we would look for DVT, but more likely, and HIV patients have an increased risk of DVT as well. That's so it makes sense to look for that. But the far more common cause is what is called tuberculosis destroyed lung or post-tuberculosis lung disease. So if you have such of tuberculosis, you basically the scarring. I mean, you can treat the tuberculosis, but the problem is that the destruction it has done stays, and that in long term leads to corpulmonale. So it's also the interpretation in a way, and the next step changes, and that felt like it needs another simpler protocol, and we must say we are quite happy with it. So it works for us. And
yeah, that makes perfect sense. I mean, thinking about the clinical context and epidemiology, I mean, when I first like my first initial reaction seeing this image and this this enlarged right ventricle was pulmonary embolism from DVT in a practice setting like, say, in San Francisco, California, versus another practice setting where you have a much higher prevalence of TB lung disease and as a leading cause. So thinking about POCUS, I mean, for those of us who are in the clinical context, including epidemiology, going beyond just an image, just the image and interpretation of the image, but really thinking through what the clinical context is and the differential diagnosis is I think so important. Always including that in any POCUS teaching is the clinical integration. Just one quick question in terms of the mitral valve and aortic. Why specifically the mitral valve and not the aortic valve, or including the why not include the aortic valve for the protocol?
Well, one reason is the geometry. So it's much harder from subxiphoid to reach. You have to be really flat to you can see it sometimes, but it's much more difficult. And the good news, or the one of the reasons is that we're not looking at degenerative valve disease. We're looking at post-traumatic valve disease. And the good news is that the good news for girls is that the mitral valve is far more commonly. So the mitral stenosis is, I think, present in 70% of all of all rheumatic post-traumatic heart problems, whereas that you have only affected the aortic valve is less than 1%. It's really rare that you do not have a mitral valve problem. So it's the mitral valve is leading. So it makes sense to look at the mitral valve, and then the treatment. I mean the treatment. Then you have in a way a diagnosis, and whether you have an additional aortic stenosis, it doesn't change, or an aortic valve problem doesn't change the acute treatment very much. That is then left for those who might treat it dilated or operated.
Thank you. And just a few comments I just wanted to share from the chat from Dr. McDonald on the ease of teaching this protocol at the district level and how practice changing it is. So thank you for that. And I'll just to mention, there's some really amazing research coming from Brazil on the use of cardiac ultrasound in specifically around structural heart disease and rheumatic heart disease as a screening tool in the appropriate clinical setting. So for those of you interested, I would check out Dr. Nascimento's work. And without further ado, let's move on to another case.
Yep. Let's see. Yeah, this is the most recent thing, and I'm really, this is interesting. So I start with a case again because it's always good to start clinical. So this is a 24-year-old gentleman who came to us, and he was started TB treatment a couple of weeks ago, and now he realized that, well, his family realized that he has yellow eyes, and he started vomiting. And of course, on the clinical examination, his liver was slightly enlarged. Spleen was also palpable, and and he admitted to drink a bit, well, 5 to 6 beers. We don't know what size. But so we have a patient who's actually taking a hepatotoxic drugs and has alcohol problems, and additionally he is hepatitis B surface antigen positive, and that is quite frequent. And again, in our setting, because in Malawi we have a seropositivity of around 6, 7, 8%. It depends on the study you cite. So it is a frequent thing, and that is now the good news. Or let me, before we come to the good news, we look at this ultrasound, and again, this is the liver, and you can see a little bit of kidney in the back there. So this is the area of the Morrison pouch, and you can see that there is a tiny black rim that is intraperitoneal fluid, that is ascites. And this ascites gives us an idea that this surface of this liver is not really straight, it's bumpy. It's a bumpy road. And that, of course, everybody knows that a bumpy surface of the liver is what is characteristic for liver cirrhosis. And so, and liver cirrhosis is indeed, well, this is a case who has already has at the same time 3 problems, but hepatitis B surface antigen alone is enough to cause that. And that has brought the idea of this project, is that we have the treatment, because hepatitis B is treated with tenofovir and lamivudine, and particularly tenofovir. And we have it because we're treating hundred thousands of HIV patients with that. So there is now, in the recent years, there is an increasing rollout of hepatitis B treatment in resource limited setting. Next slide. And that, of course, is backed by WHO guidelines. And WHO guidelines, these are very new from 2024, so they are quite new. And WHO guidelines usually make things really easy whom to treat. But let me guide you through these treatment indications in the guidelines. So 1.1 is significant fibrosis, F2, or cirrhosis, F4. And you should do that either by clinical criteria or using a non-invasive test, which is the APRI score, that's feasible, or transient elastography. And you can imagine that we don't have transient elastography in Malawi. I think there is 1 or 2 machines in the whole country. Alternatively, you can start on 2 by hepatitis B DNA more than 2,000, and you guess it already, we don't have hepatitis B DNA quantitative up to now. Then you can start on the presence of any of the following, which is co-infections with HIV. Okay, HIV patients we treat anyway. Family history, immune suppression, comorbidity. So that's a little bit vague. And then finally, and that is probably the most easy, is persistent abnormal ALT levels. And persistent, but that requires that patients come back. And of course, it would be nice to have something where we can add on, where we can see right at the first visit that we want to treat this patient. So the APRI score, as I mentioned, that's APRI score, for those who don't know, it's basically, it needs only the AST and the platelets. That is quite easy to calculate. But what we thought is, can't ultrasound help here also? And next slide. What we developed is the PUSH protocol. It's basically a protocol for hepatitis B surface antigen positive patients. It works, of course, I guess, for hepatitis C as well, and to determine whether they have cirrhosis, and of course whether they have HCC, which unfortunately we see quite often in patients with hepatitis B. Why is that protocol needed? Or, well, basically because, as I said, hepatitis B surface antigen is frequent and treatment is available. The other non-invasive liver stiffness measurement, for example, is not available. A lot of serology tests. We only have surface antigen rapid tests, no further serology, no DNA. So, and And yeah, and that is basically that drove us. And the question is often, what do you feel about HCC? But HCC in our setting, we don't have any treatment, so it's not really that relevant that we diagnose it early, because we cannot do anything about it anyway. How do we do the push protocol? And we basically used 3 windows on the next slide. I think it's the one. Yes, we use an epigastric longitudinal, which we call the shark view, because with a caudate lobe, it looks a little bit like a shark. We then the subcostal transverse look at the liver, and then the transcostal. And in these, we look for basically 4 simple signs. That is liver surface. Is it nodular or is it smooth? How is the echo pattern? Is it coarse or is it fine and velvety? Then the vessels, are they normal? Are they normal in amount, or are they truncated and reduced, or tortuous and curvy? And then finally, we look at the caudate lobe, which is in the shark view, whether it is enlarged. And then in all of these views, we look for focal lesions, which could be an HCC in an hepatitis B surface positive patient. And then, of course, that is in a way the push protocol. And yeah, and I think it for us here at the Lighthouse, we trained our clinicians, and it worked very nice. And they were very excited in taking part in developing this protocol. And yeah, and I think we use it, and we use it, and it's rolled out in all our clinics. So we have a couple of clinics throughout Malawi, and a lot of the clinicians use it.
Wow. Well, thank you so much for sharing this protocol. I mean, taking a step back and looking at the protocols you've shared thus far, FASH and curls, this is definitely in the realm of POCUS and POCUS education, and what has traditionally been taught as focused clinical questions. This is definitely, liver cirrhosis is a expansion in terms of the scope. And I'm curious how this research, how this protocol, publishing of this protocol was met in the kind of the hepatology community. These focus questions this is really like pushing the frontier of what can be within the scope of POCUS. I'm kind of curious to hear your take on that.
Yeah, no, I mean, I think that the main feedback that I think generally it was welcomed, particularly from hepatologists throughout the neighboring country. I mean, we basically in Zambia, we had some experience. I'll share that later. But I mean, the one reason, the one counter argument that came was like, okay, but for diagnosis, it was mainly the HCC, because HCC is very difficult to determine, and you need contrast ultrasound, you need all these things to make sure that you don't miss a HCC. But I think that, that is unfortunately, it is not in our setting, because we have nothing to offer. We couldn't we can't do radio ablation, we can't do chemotherapy, we can't do anything about HCC. HCC is palliative care. And in that sense, it doesn't matter whether you miss it or you will sooner or later you will find it. It's important that you find the patients who you should put on treatment. And I think, yeah, I mean, I mentioned already in Zambia, so that was a very positive request, that from the hepatology department in Zambia, they asked us to come over and do a training. And yeah, and there is some data coming out of that. So maybe
yeah, well, we're looking forward to hearing more about the research that results from Zambia. But I think once again, the kind of the clinical context, we're talking about a protocol for patients who now have potentially access to treatment with tenofovir, but based on current protocols, to qualify for treatment, many of those, as you had shown in that flow diagram, it's difficult to qualify for treatment because the exams, the elastography, the lab tests are simply unavailable. So the clinical utility of a protocol like this is expanding access to treatment for patients who otherwise wouldn't qualify, is I think the big take home. We have a kind of a question from Dr. Slimani from Morocco. Bienvenue. I think this is a question that can apply even more generally for point of care ultrasound. Do you have a database for ultrasound images and videos where they're saved with a corresponding patient report and record? So I think this is kind of more general workflow question in terms of POCUS, and Dr. Bergman mentioning, and feel free, Dr. Bergman, to comment of different resources. I know we at GUSI have a free device agnostic scan archive for sharing images and getting feedback from experts. Maybe you can comment on your experience at the Lighthouse. And I know that answer to that question from Dr. Slimani on saving images and videos and differs from context to context, and the availability of medical records or electronic medical records, rather.
I want to say something on that because it raises an important question, and that is of course the trainability. And I mean, trainability we're talking always a little bit about, but often, you know, it's one thing to do an ultrasound training on push, but the next thing to go then and say, well, now it's you and you decide. And what we find, what our clinicians do on a daily basis is using, well, we don't have what we use very often is we just use WhatsApp. So basically that we have a WhatsApp group, and they will film the screen and say, hi, do you think this is cirrhosis or not? So in a way that is a very low cost image sharing, and the image quality, of course, it's not DICOM, and it's not the radiologists probably will throw their hands up, but yeah, for the big things, it's very often it's enough just to share a WhatsApp clip. I don't know if that fits to that question, but it is it's just an experience that I find quite a solution that I find quite helpful, because it is real time, because, you know, it's nice to upload something somewhere and then somebody at this later time, somebody sits and looks at it with you, but in the end you have a patient on the bed and they want to get the patient off the bed and get the next one. So basically they want to also to help with the decision. So, and WhatsApp allows that if you have somebody to go on real-time decisions.
Great. And just one last comment about the potential use for, you know, AI to as an adjunct to train, to help train or give feedback. I think you know, I would say let's put a pin on that, because that could be an entirely another conversation and another webinar, or maybe a series of webinars on the applications of AI. So thanks, Dr. Slimani, for your comments and response. I can't believe how quickly the time is going. Let's go ahead and move on. We have a couple more cases for you all. Go ahead, Dr. Heller.
Yeah, this is a case from a more, let's say, a more traditional tropical medicine. This is a Malawian fisherman with back pain. He's 23 years old, and well, he came to the central hospital, which is about 100 kilometers away from the lake. And he complained about pain in the back about a couple of weeks. And what we did is just a little bit of fever. We did a normal ultrasound, a normal point of care ultrasound, bedside ultrasound, and we found the kidneys. And you see, this is the kidney. I don't remember now whether this is the right or the left, because they look very similar. You can see the rough. Maybe you can point out the kidney, and then in the center of that kidney, you see there is this anechoic connected tubes, which are anechoic is usually fluid. So this is what we call hydronephrosis, and you can even see at some images you can see the ureter leaving the kidney. And then what you do, particularly if it's bilateral, you think about, well, the problem must be somewhere downstream. So we move to the bladder, and that's, I think, on the next clip. You can see the bladder of this young gentleman, and you can see that there is not only wall. This is the bladder again. Anechoic is the fluid, in this case the urine, and then you can see that dorsal on the particularly On the right side, you see this massive wall thickening, and I mean this is unfortunately not this is not schisto anymore, but this is a case of bladder cancer, which is induced by schistosomiasis. So he had a chronic. We found the eggs in the urine, and so this is a consequence of schistosomiasis. And schistosomiasis, and then maybe go to the next slide. Is a more traditional tropical medicine ultrasound topic. And there are by now also sonography for urinary schistosomiasis protocols like FASUS. They took the same abbreviation, and it looks, and as you can see on this graph here, the degree of changes in the ultrasound of wall thickening, etc., correlates with the egg load. So it is, and it's again the question here, and this work was also, can we train it? How simple is it? I mean, I'm not enough of an schistosomiasis specialist or treating not enough cases to know how much impact this has on your clinical decision making. But anyway, it is also showing that this is, of course, a possible application of point of care ultrasound. And on the next, I think I wanted to mention briefly, because it is so iconic in tropical medicine ultrasound, that is the other schistosomiasis, the schistosoma manzoni, which leads to periportal liver fibrosis. And you can see this pipe stem here, particularly in D, E, and in F. This is the WHO classification. So that is all well researched over decades, and we know that the Asian forms have this more mesh-like septal fibrosis, but for us it's more the other side. And to give you another example of the liver of a schistosomiasis induced liver changes on the next slide. Here you can see this. On the left one, you see the portal, which is pretty prominent and enlarged, and then you can see around the portal branches you have this white fibrotic connective tissue running into the periphery of the liver. And on the other one, again, you see this is more transcostal view. You see in the distance, you see the dilated and big portal vein, because it causes, of course, portal hypertension, which secondarily leads to ascites, which we see on top. And again, you see in the liver tissue, you see these bird claws, fibrotic changes, which are pathognomonic for schistosomiasis. So that's a traditional, but it's, as I said, I have not enough experience to know how it affects the treatment. But I'm sure, well, you can find maybe people who require endoscopy, or, well, it's for the schistosomiologists to decide. Next, on the next one, I think I just want to mention the other one, which is well as iconic and as well researched, and that is cystic echinococcosis or hydatid disease. And here the ultrasound, there is a well-described classification, and in the first stage, when you look at it, it looks rather academic and confused classification, because you see 1, 2, 3 is split in A and B, and then 4, 5. But actually, it is very helpful, and it is clearly also affecting the treatment. So if the classification is leading to clear treatment decisions, and that's why ultrasound for hydatid cyst is really the image modality per se. It's better than MRI or CT scan. And on the next slide, I want to quickly just say that here this is a different. They also used the FAS abbreviation, focused assessment with sonography for echinococcosis. And basically what they did is they did a 20-hour course for primary healthcare providers to basically to identify the cysts. And if you find cysts in an endemic area, I think this was done in Argentina, in a rural area in Argentina. And if you find cysts, then these children or young adults were referred and then assessed in the next hospital. And again, it's a more public health way application of point of care ultrasound. But again, I think it's quite impressive, and they had quite good. And again, it shows that the trainability, which often feels like the most difficult thing, is if you focus on something, then can be quite quick.
Fantastic. Thank you. Thank you, Dr. Heller. I mean, we're seeing now kind of expansion or other examples of POCUS and infectious diseases from kind of the more classical schistosomiasis. I think this particular research from Argentina, thinking about POCUS as not just a kind of a diagnostic tool or rule-in test, but also potentially a screening test in the appropriate clinical setting, and certainly more research needs to be done. But I do think from a public health standpoint, it is worth mentioning. In the interest of time, we're actually at the top of the hour. I can't believe it. We did a very similar talk at the American Society of Tropical Medicine recently. And I think because of the conversation and the dialogue, it took us it took us a little bit more time to cover a lot of these cases. But I think if Dr. Heller, you're okay with it, we can kind of stay on for a few extra minutes here for those who
Great.
are able to, who may want to ask a few more questions. And we just have a couple more slides. So this meeting will be is being recorded and will be available to those who've registered. Thank you so much for joining us. For those who have to hop off, and we will stay on for a couple more minutes to finish the presentation and take some questions as they come in. All right, great. And we'll just kind of go through one last case, and then we'll close. Thank you.
This is a case which is much more, let's say, non-tropical, I would say, but in this case, it has a tropical twist to it. So it's a 56-year-old woman we saw at our HIV clinic here, and she was HIV positive, but well controlled. It had nothing. The HIV was not her problem, but she complained about increasing right shoulder pain. And you can see here that this is her left this is her left shoulder. You can see the scapula nicely, and on the right shoulder, you can see how the bony structures are hidden in a swelling. So it was swelling, and obviously, if you have an ultrasound and then you put the ultrasound on, even if you know, on the next slide, you can see the ultrasound of the scapula. And of course, nobody is at least I haven't met a scapular expert, but you see on the left side, the good thing is God made us symmetric, so we can use the healthy side to compare. And there you see the bone, where the arrow is, and then you see the muscle on the left side. At first on the normal side, you see the bone, then above you see the muscle, and then on top of it is the echogenic subcutaneous skin or what. On the pathological side, you can see that there is the bone at the bottom, and then there is muscle, but then there is, before we reach the echogenic skin under the transducer, there is an area which is hypoechoic liquid and which is compressible. So that is likely fluid. And from you can't see it now, but it's a centimeter away. And of course, it leads itself to say, well, let me stick a needle in here. And we did that. And I think on the next slide, you might see the outcome. It is pass. And of course, with that, you would need to, you can refer this patient easily to the right surgical department where they can drain it. This is what is called tropical pyomyositis. It's a subcutaneous or around the fascia infection, which is not very red or hot, but it is more of a little bit more chronic and a mixed bacterial infection, which needs drainage. So I think that's probably more. I don't know how, Mena, your experience. Are you use ultrasound for skin infections or?
Yeah, I would say probably one of the, as far as easy to learn introductions into POCUS and POCUS education is skin soft tissue for something so common and something that, traditionally you would be palpating. And, I think those of us clinicians who've ever tried to drain what we thought was an abscess and found that there was in fact no pus would benefit from having ultrasound to not only identify collection of drainable fluid, but also to know the anatomy, the surrounding anatomy, how deep is this loculated pocket, so on and so forth. So I'm pleased to kind of end these cases with something very, I would say, common, applicable skin and soft tissue. We've gone through several cases from and protocols from focus assessment sonography, HIV for extrapulmonary TB, the CURLS protocol, a simplified cardiac protocol in resource limited settings. We went through the PUSH protocol for cirrhosis in patients with hepatitis B. We also talked about schistosomiasis. These are certainly not, these are just several of the applications of point of care ultrasound, certainly not limited to these applications, but I think a good introduction. And we also heard about new research in the realms of public health. POCUS is potentially a screening tool in the appropriate clinical setting. Their education and training is one big step, image and acquisition of devices, of course. The comment from Dr. McDonald on a very rate limiting step. I think definitely warrants another conversation and around suggestion ways to advocate and acquire avenues to acquire devices. But I just wanted to take a few minutes here towards the end before we take some questions to just mention some of our own experiences in POCUS and POCUS education and training at a large scale, really centering if anything was taken away from these different cases and protocols, is that the context really is the key to the responsible ethical use of POCUS and understanding not only the epidemiology but resources available both in terms of treatment and how this can potentially change treatment and public health. So this is much more than just an image acquisition and interpretation device, but one that's used by clinicians in order to hopefully help make a better clinical decision and bring patients closer to their providers. And in terms of, for those of you who might be new to learning POCUS or expanding your scope, longitudinal learning, being able to get feedback is just an important step into really being able to start using this confidently and competently and nurturing the POCUS community. And that's really what these webinars are all about, is sharing our respective expertise, is nurturing community, bridging gaps, and making connections. And so with that, we'll leave a few minutes for questions, and these are respective contact information if you'd like to reach out. We would love to hear from you, and we would love to do more webinars on the topic. There's a lot of new research coming out with POCUS in infectious disease, specifically in resource limited settings, applications for things like dengue, malaria, and other infectious diseases. So please feel free to reach out to us, and we'll stay on for a couple minutes here if there are any further questions. Thank you so much.
Yeah, we took longer today than last time.
We
Also
did.
get quicker when you learn.
Yeah.
If
Okay.
there are anyone who has comments or questions, we are more than happy. Oh, see some UCLA people.
Lots of thanks. Thank
So thank you.
yous. From
There is a question.
okay. This is Dr. Solani from Morocco, radiologist from Morocco, on portable devices and general machines that you're using. I can say from my perspective, I've used cart-based devices and just about every portable device that's currently on the market. And what I typically, advise is any device is going to be useful in the appropriate context. That every single machine has some limitations, and understanding what those limitations are. is important to really being able to get the full use of. But in terms of portable devices, I mean, there's no question that over the last 10 years, it is a completely different landscape in terms of what is available in for these applications that you mentioned, Dr. Heller. At Lighthouse, I'm curious if you all, from this question from Dr. Slimani on machines and are you?
Yeah, no, I mean, we use portable machines because I mean we use as I said we have one non-portable, but we have, I think in all our clinics we have 5 or 6 portable machines because we take them to the ward, we go to the bedside. We are not yet on the handheld wave, I would say, because particularly also because what I learned is, well, I have no much experience with that. I learned that the battery life might be a little bit of a limiting factor there, that you can't, but what we use is a box, like a handheld 5 kg portable black and white machine. As you might have seen in all the protocols that I mentioned, we did not use color. So I feel that for the infectious disease, probably the color is less. I mean, it's nice when you have color, because then you can switch it on and you see where the color is. There's a vessel, so don't stick your needle there. So, but otherwise, we don't need much. We don't need much color or other Dopplers. So we use pretty simple machines, and for the same reason that you mentioned that it's a question of how much do they cost and how can you get more, because we also have to admit they break. I mean, probes break from time to time, and so if you don't have nothing more frustrating nowadays for our clinicians than when their probe is broken, because they feel like, oh God, then how should I diagnose TB? So it's we really you have to consider the resources and the flow of on replacement service.
Yeah, we have a couple of questions here that I wanna address, with just one comment. Oh, well, this is actually on in terms of gel and devices. Dr. McDonald commented here, which I can absolutely attest to. Gel is usually pretty easily available, but if it isn't, there are other options. What you really need is a medium that's going to transmit sound waves. Really, in a pinch, you could even use water, and a thin film of water. But in terms of like a lubrication, there are multiple recipes online to make a kind of homemade gel for lack of other options. So to answer that question, yes, I think gel is actually quite an easy way to address that issue. But we have 2 questions around one around POCUS and dengue. Thoughts on POCUS and diagnosis management of dengue. And I know there's some new research that's coming out from Brazil. I personally am not a POCUS and dengue expert, and I really look forward to learning more. But Dr. Heller, I'm not sure if you have any comments on that.
Yeah, absolutely. That's a great question. Thank you, Dr. from Guatemala. That is nice. I did my first outside of Germany work was in Guatemala. Love the place. But yes, there is something for dengue, and I think ultrasound has a big role in two ways for dengue. Number one is in not in the diagnosis. I mean, the diagnosis is obviously a viral infection, and you have rapid tests, and I guess you have them widely. But then for the grading of the severity of the disease, so there is a lot of the effusions help you, which show you that there is a leakage, plasma leakage, and also the gallbladder wall thickness is a quite well researched and quite well understood predictor of more severe disease. So indeed it can help you in the not in the diagnosis per se, but in the assessment of whether you want to admit this patient or you want to send him home. Because I guess in Guatemala, if it is like in many other of the South American countries around this time, there is a lot of dengue. There was a big dengue outbreak this year. So what you mentioned, Mena, there was just recently I came across a FASD, so FASD for dengue. And if you Google it, it was actually only in Portuguese, which as you speak probably Spanish shouldn't be a problem because I was able to read it. So they described from Brazil, they described a focus protocol for dengue for exactly what I said, the assessment
Mhm.
of basically for the assessment of how severe it is. Of course, in the long run, also in the management, but that then is, and I know there is some research or some experience in Malaysia. They use it a lot for guiding fluid treatment, because the problem is, of course, with dengue is how much fluid do you need to give, and when are you doing your patient good, and when do you start to harm your patient with the fluid? And that there again, ultrasound can help, almost more conventional lung ultrasound, to see if you start getting pulmonary edema or fusion. So that's exactly where I think dengue. Well, I was waiting for the phase 2, but I saw it from I think it's the Emergency Journal Brazil, something like that.
Yeah, I've got it pulled up here on my iPad. Extended focus assessment, sonography, and dengue, EFASD, and the lead author is last name is Tambelli, Tambelli. Okay, great. And a question from Dr. McDonald, Anna McDonald, on looking at the feasibility of HCC screening to the primary care setting in high resource settings. And so, lots of patients with chronic Hep B or cirrhosis, but lots of barriers to get regular scans or going through the traditional pathway through radiology. If there has been, any data that you know of looking at HCC screening in the primary care setting. That's a very good question.
I think it's a very good question, and I mean, I think there is a slight problem, of course, we have, because we always assume in high resource setting everybody gets everything, but reality is often quite different. And I agree with you that this is something to look at. So maybe there is some low resource setting even in the US or in parts of Europe. So the question of screening, I mean, I think it is indeed complicated, let's say, because the liver is very nodular in hepatitis B, and then at some point these nodules are too nodule, and then we call them HCC. So it is easy. It needs a lot of experience. I mean, I would assume. I mean, I think we all who do ultrasound, we know nothing in ultrasound is really secret. I mean, it's not unlearnable. I mean, you need the experience, but I would not be aware that anybody pushed down that line, because usually what happens very often when you do these screenings, that you get results which are a little bit difficult, and then you say, okay, let me do a contrast ultrasound, let me do a CT scan, and so it might be pushing the border too much. But of course, again, like I said before, I mean, if you had asked me a couple of years ago if I want to screen cirrhosis by point of care ultrasound, I would have said, nah, that's beyond the borders. So it's really depending on the setting, and does it do the patient more good than harm? And if that is, then we should do it if it does.
Yeah, I mean, I couldn't agree with you more. One of the other limitations, I mean, there's certainly a lack or a need for more research, for more POCUS research in the primary care setting. As a lot of us know, POCUS is really most of the research has come from our colleagues in emergency medicine and hospital medicine, critical care. And so I know one of the big barriers to really implementing primary care POCUS research has been just having clinicians who are in fact trained to be able to do POCUS. And so I think this is, in terms of future directions, not just of POCUS in infectious disease, but POCUS in general, is how can we meet patients earlier on in the continuum of care to be able to make a difference clinically in a way that that can potentially impact outcomes in a positive direction. So not technology for technology's sake or imaging for imaging's sake, but imaging it within a clinical context to effectuate a positive outcome by centering patients. And with that, go ahead,
just
sorry.
before you close, I want to give one final comment, because
Please.
I think the interesting thing is that a lot of the use of ultrasound is very cultural, you know, that, and I know that the US has the more British way of radio, that it was traditionally very radiology tool. In Germany, for some reason, and don't ask me why, it was always so I guess almost every family practitioner has an ultrasound machine. So the ultrasound was, it wasn't considered really a radiology tool. It was more something that medicine and family medicine, that physicians do. So it's really just, so it works. That one I can justify for Germany. But of course, it needs always the same thing. You need to have a machine, and you need to have the training. And then, well, if you do things you can't do, then it's not good. But if you do the things you learn, then it's helpful.
Right.
Yeah,
like all things in medicine, right? Well, with that, thank you all for joining us. Thank you, Dr. Heller, for your time and for sharing sharing your work. And I also just want to personally thank you as a POCUS educator and clinician that has transformed my relationship with patients and my relationship with the practice of medicine. Your work has significantly impacted me and so many other of my colleagues and fellow learners and teachers. So thank you so much. And we hope to see you all at our next webinar. So thank you all. Take care and best wishes. Bye-bye.
Thank you. Bye.